Hello, welcome to Vermont-Oxford Network Grand Rounds. Today, we'll be discussing the translation of evidence to practice, cooling for hypoxic ischemic encephalopathy. I'd like to welcome you on behalf of the senior editorial team, myself, Bill McGuire, Michelle Fiander, and Charlotte Crowley, as well as our senior editors and our host of associate editors. Today, specifically, we'll be drawn by two guest discussants, Marie Berg, who is the author of this updated review, and Deirdre O'Reilly, who has spent a great deal of time thinking about cooling, the needs for regionalization of cooling, and where we need to go in the 21st century. These talks are sponsored by the Vermont-Oxford Network, and the reviews that I will be discussing can be found at our site at Cochrane at Vaughan. As a point of disclosure, I am Vice President of Vermont-Oxford Network and coordinating editor of Cochrane Neonatal, and have no other relevant financial issues to disclose. What we hope to get out of these sessions is to develop an understanding of the strengths and weaknesses of evidence provided by systematic reviews and meta-analyses that inform our practice of neonatal perinatal medicine, with today's focus being on therapeutic hypothermia for infants with hypoxic ischemic encephalopathy. So first, let's set an understanding of the meaningfulness of this problem. According to the World Health Organization, hypoxic ischemic encephalopathy is the 5th leading cause of death worldwide for children under 5 years of age. Hypoxic ischemic encephalopathy carries with it some very serious downstream effects. It affects 1 out of 6 in 1,000 live term births, of whom 15 to 20% will die during the newborn period, and 25% or more may have permanent neurological deficits. When we think about the mechanism of injury in hypoxic ischemic encephalopathy, I'm sure that we're all aware at this point in time that on the cellular level, we think of sort of a two-punch attack. The first is the initial injury, which leads to cell necrosis. And of course, when we think about trying to stop that, we think of all the preventive issues around birth that can assure us a child who makes a good transition. But the child who presents to us with hypoxic ischemic encephalopathy has then a second phase of injury during a reperfusion period that leads, after the oxidative stress and excitotoxicity of the injury, to inflammation and cell death. And this secondary phase is what we are concerned about when we think of a window of opportunity to use cooling to prevent this injury. And so we have the initial injury and necrosis thereafter, but then there's a window of opportunity that is someplace around 6 hours that will allow us to consider whether or not we can influence reperfusion injury and help improve outcome. The idea of using cooling in these sort of injuries is clearly a hot topic, both in the neonatal world and the adult world, for heart attack victims, for stroke victims, but in our case, we're focused on the infant with hypoxic ischemic encephalopathy. Cooling has been shown to be very effective in animal models. In work by Alistair Gunn and colleagues, it's been shown that mild hypothermia, that's cooling to 32 or 34 degrees centigrade, is neuroprotective, and that brain cooling should be initiated as early as feasible. Now, I showed you that window of opportunity. The closest you come to that initial injury, so preferably within 2 hours, in animal models, you see your greatest effect, and the effect attenuates after 6 hours, and that cooling should be considered for a period of 48 to 72 hours. Here's just an example from Gunn's animal models looking at neuronal loss, and you can see that in all areas of the brain, there is significantly less neuronal loss in the animals that have been cooled. So, what do we know about the clinical trials of therapeutic hypothermia in newborn infants? Well, let's start with the issue of who might benefit from cooling. And as you'll see as we develop this discussion, this turns out to be a very important point. The trials most of the trials, have looked at newborn infants who have very specific and detailed entry criteria. They have to have evidence of peripartum asphyxia, which may include APGAR scores of less than 5 at 10 minutes, the need for mechanical ventilation at 10 minutes, cord pHs that are below 7.1, or base deficit or 12 or more, and evidence of encephalopathy according to Sarnot's staging. Sarnot's staging was initially done in infants over a period much longer than these first 6 hours of life, and it includes a variety of findings from hypotonia, lethargy, stupor, etc. Here I have a chart just showing all of the various findings of levels of consciousness, spontaneous activity, posture, tone, privative reflexes, and signs from the autonomic nervous system. I think it's clear that this is actually a relatively complicated assessment, and one that you and your unit has to take some time to completely learn and appreciate. This is particularly true as you work with groups and caregivers referring patients to your hospital. There are a variety of interventions that have been used to cool infants, and all of these interventions are included in this review. There's head cooling with temperature servo control, whole body cooling, and phase-changing materials. And here are just some examples from the classic trials that use these various methods. The Glucomid trial, the CoolCap trial, used this setup of cooling, preferentially cooling the head, whereas many trials, including the NICHD trial of Shankran and colleagues, used thermal mattresses that maintained the infant in a cooler environment. And trials such as the Toby trial in the UK did similarly. Perhaps the most innovative trial was done by Jacobs and colleagues using phase-changing materials. In this case, and in most of the cases of phase-changing materials, without temperature servo control. In this trial, hypothermia was achieved by turning off the ambient heating systems and by applying hot-cold gel packs at 10 degrees centigrade around the infant's head and over the chest, so that the rectal temperature was reduced to 33 to 34 degrees centigrade. So what do we now know from these trials? One thing we know is that there's actually been an explosion of trials. Since the initial review, there are at least twice as many trials to report, 29 trials involving over 3,400 infants. Here we're taking a look at the meta-analysis of the effect on death or major disability. And I think that you can see here that there are 4 trials that use selective head cooling, 7 that used whole body cooling, and only 2 of the trials that used phase-changing materials reported on the combined outcome of death or major disability. I think you could also see that the results that you're aware of from the very first trials really are only amplified and made more precise by the ongoing evidence. There is a 23% reduction in the risk of death or major disability associated with head cooling, a 25% reduction with whole body cooling, and interestingly, a greater reduction in the few studies that reported on phase-changing material. Overall, there's a 25% reduction in the risk of death or major disability, which could be as much as a 32% reduction to as little as an 18% reduction. When it comes to mortality, many more of the studies report, and so we have a much more precise estimate. We have 7 trials that involved head cooling that report on death. We have 9 trials reported on whole body cooling, and we have 10 trials that reported on phase-changing materials. And again, similar to when the first trials came up, what we see is an independent reduction on mortality. Fewer trials looked at selective head cooling, and although the point estimate suggests a 21% decrease in the risk of mortality, the confidence interval is consistent with no effect. But I think that's probably a sample size issue, as fewer trials report in this group. When we look at the trials of whole body cooling, we see a 20% reduction in the risk of death. And interestingly, the trials of phase-changing material without servo control there is a relative risk of 0.58, so a 42% reduction in the risk of death. And the confidence interval is fairly precise and tells us that there are very profound differences in the reduction in death that could range from 0.47 to 0.72. Overall, we see a 29% reduction in the risk of death that is highly significant and precise in terms of the confidence boundaries. Looking at major disability alone, we recognize from the original trial that looked at the combined outcome that fewer trials of phase-changing material report on this. But in fact, there is a decrease in major disability reported in the selective head cooling trials and in the whole body cooling trials. And although there is no significant reduction reported in the phase-changing material trials, this may well be an issue of sample size. Overall, we see a 30% reduction in major disability, which could be as much as a 42% reduction or as little as a 16% reduction. And so we are not, in our increased survival, winding up with an increased number of infants who are then disabled. To quickly summarize this and to look across all of these studies, here we have the selective cooling studies, the whole body cooling studies, and phase contrast material studies. And what we see is that there is a reduction in death throughout these studies, and for the selective head cooling and whole body cooling studies, a reduction in disability. When we look at the numbers needed to treat, we recognize that this is a pretty profound therapy. For some of the benefits, it could take as many as 20 infants or as few as 8 or 9 infants to see the benefits of cooling. Of course, we do worry that there might be significant complications related to cooling. We are changing infants' basic homeostasis, but we really don't see great changes that worry us about at least the immediate side effects of cooling. You can see here that the risk of arrhythmia is very imprecise, but the point estimates suggest that there is probably little risk, as worst in 1 out of every 100 infants. More infants who are cooled do experience some hypotension requiring therapy, but again, looking at the number needed to treat, that's 1 in every 25 infants. The same being true with PPHN. 1 out of 100 more infants requires inhaled nitric oxide, but in fact, there's a reduction in hypoglycemia, and there's a slight increase in thrombocytopenia and DIC, but none of these translate into increased risks of mortality. So when looking at this evidence, even before this explosion of evidence, but after the first 8 or 10 studies, ILCOR made a very strong recommendation. It said that intensive care nurseries should now consider adopting one of the validated protocols for the selection of term infants with HIE, be appropriately equipped to train staff and offer hypothermia according to the protocol of the currently published large hypothermia trials. And I'd like to actually focus on this for a second. ILCOR spoke of adopting one of the validated protocols. And of course, that's not what happens in practice. We have that job of taking the trial data, which shows us efficacy, and determining how we can make it effective in our contexts. So efficacy, as we've talked in these sessions before, is the benefit of using an intervention for a particular problem under the ideal conditions of the trial. But effectiveness is the extent to which a specific intervention does what's intended to do as we use it in a broader population. And of course, efficiency, which we don't always discuss, is the use of resources, which needs to be thought of when it comes to any technological issue such as cooling. We know about the efficacy. Mild hypothermia is a promising therapy in highly selected populations of infants with moderate to severe hypoxic ischemic encephalopathy when treated before 6 hours of age. But we don't know everything about effectiveness or efficiency. Does it work in the most severely affected infants? Does it provide benefit to less severely affected infants? Does it work outside the restricted time window predicted by animal models and tested in the clinical trials? Is there a best approach, whole body, selective use, or of phase contrast material? And how does hypothermia relate to other therapeutic interventions? We have some answers to some of these questions, but many remain unsupported, and it's not completely sure what we should do. We know it's a promising therapy in a highly selected population treated based on the protocols. Infants with moderate to severe hypoxic ischemic encephalopathy treated before 6 hours of age. But as I noted before, there are many unknowns about the degree of severity, about treating outside the time window, about what type of cooling conveys the greatest approach, and the relationship to other therapeutic interventions. And so let's explore that in the remaining time that we have together. And I'll start with the issue of current practice, and of course, the issue of therapeutic drift. There's a nice survey from 2018 from Oliveira looking at practice in the UK, and I think it informs us probably about practice universally. The authors note that although major cooling trials excluded babies with mild encephalopathy, there's a fair amount of anecdotal evidence suggesting that cooling is often offered to these infants. And they report a national survey that includes the practice of treating mild encephalopathy, as well as other practices around cooling. They received responses from 79% of the cooling centers, and of these centers, fully 75% offered cooling to infants with mild encephalopathy. They did ask the units what their rationale was. And basically, the majority said that they were concerned that even with mild encephalopathy, there was a risk of long-term adverse neurological consequences. And they also pointed out that that SARNOT scoring that I alluded to earlier and the grading of neonatal encephalopathy after birth isn't always so straightforward. And we can discuss that more when we flip the classroom and we have a chance to talk with our experts. They know that mild encephalopathy may progress to moderate encephalopathy outside the cooling window, or seizures might appear outside that window, and then they'll find themselves very distraught that they didn't cool that infant. And at least a third of them thought that cooling is mostly a safe treatment. For the 25% that did not offer cooling, they basically said that the majority of kids with mild encephalopathy do well enough without it. There's no evidence from the trials to support this, and that cooling is not without side effects. Here we take a look at some of the various practices that were used, and you can see that in almost 1 out of 5 centers, they allowed themselves to cool up to 12 hours of age. In terms of the duration of cooling, 61% cooled for the full 72 hours, but many had other protocols and approaches to when they would stop cooling. Most, 89%, used morphine in addition to cooling to treat whatever the pain and discomfort that was perceived. Enteral feeds were held in 42% of infants, which is unclear from the trial. In terms of imaging, the majority of infants who received cooling are imaged, and developmental follow-up, if cooled, was reported in 75%. I think that's a high number compared to what happens in the United States, where this is a big issue about losing these children from our neonatal follow-up clinics, perhaps to neuro follow-up clinics. What about the issue of cooling later? You saw that many of the centers in the UK treated up to 12 hours of age. There is a trial that in fact was included in the meta-analysis that I presented to you that did take a look at later cooling, and I included it in the initial analysis because it did have an untreated control group. This group, Laptuk and colleagues from the NICHD, wanted to estimate the probability that hypothermia initiated 6 to 24 hours after birth reduces death or disability. And they took a look at infants who were up to 24 hours of age. The analysis is presented to us in a conventional way and also in a Bayesian way, given pre-specified values, given the limited sample size. They treated 168 infants, 83 with hypothermic therapy, 85 were not cooled. In this group, you can see that the average age at cooling was 16 in the hypothermic group and 15 for the non-cooled group. In the conventional analysis, we see that 24.4% of infants who received hypothermia had the primary outcome of death or moderate to severe disability, compared to 28% of the infants who were non-cooled. They conclude that, based on their Bayesian analysis, that hypothermia may have some benefit, but it is uncertain. So this trial does not really tell us about that group that we do commonly cool. One question that has come up is whether or not cooling is effective in other care contexts, particularly in lower middle income countries. And there is one recent trial from the Helix Consortium that took a look at infants with moderate or severe neonatal encephalopathy in low and middle income countries. This was an open label randomized controlled trial in 7 tertiary neonatal intensive care centers in India, Sri Lanka, and Bangladesh. They enrolled a somewhat heterogeneous group of infants. The inborn infants were very similar in terms of criteria to the infants treated in the classical trials, but outborn infants were treated in a much broader way, namely that they did not have a cry by 5 minutes of age. Infants who made it to the centers were treated with rather conventional whole body hypothermia, and the primary outcome was death or moderate to severe disability. They recruited 408 infants, 202 into the hypothermia group and 206 in the control group. 50% of the infants in the hypothermia group died, compared to 47% in the control group. The authors were understandably disappointed in this. They note that hypothermia did not reduce the combined outcome of death or disability at 18 months after neonatal encephalopathy in their setting of low income and middle income countries, and significantly increased death alone. They were very cautious in their comments. They thought that therapeutic hypothermia should not be offered for treatment in low and middle income countries, even when facilities are available to give such treatment. I certainly understand the level of concern and the difficulty of translating a practice that has been shown to work in our high income settings, but is unclear about how it can be established in lower middle income countries. But I think that at least the wording of this caution is not clear and implies that somehow hypothermia itself won't work. We know from their own trial that they were extremely successful in delivering hypothermia to the infants who were randomized to cooling. This trial of temperatures, here the control infants, here the cool infants, looks strikingly similar to the reports from the NICHD trial and others. So why say that it, quote unquote, doesn't work in low and middle income countries? Well, here's the meta-analysis of the trials that we previously discussed, but separated into the trials conducted in high income countries here on top and the lower or middle income countries on the bottom. In terms of how this sugars out, more studies are done with phase contrast material in the lower middle income countries, which is not at all surprising based on what's available technologically. But what you clearly see are very similar results between the trials done in high income countries and the trials done in low income countries. And in fact, regarding mortality, there is a very strong overall result on mortality when we look at the trials from lower and middle income countries seen together. Why then should we be concerned? There's no heterogeneity. There's no difference in this important outcome of death. So what is it that we should be concerned about in this different result that is reported in the Helix Consortium? Well, one possibility, and this of course is speculation, that it has as much to do as the infants enrolled in the trials, as opposed to the capacity of the centers to deliver hypothermic therapy. And here we have analysis that includes some studies that are added to this, that did not make our original cut of studies that had strict entry criteria. And so on top here, are the studies that used a more simplified enrollment criteria that did not necessarily demand an antenatal antecedent to the perinatal asphyxia, that did not demand cord blood gases, etc. And so several studies are added to the analysis here, and the outborn infants from the HELIX study are also included separately from the inborn infants. And what we see is quite striking. We see that there's an increase in mortality in the studies that reported on broader populations with simplified enrollment criteria compared to the standard enrollment criteria used by a variety of studies that used several different approaches to cooling itself. This result is very heterogeneous, statistically very different, and leads me to at least speculate that the single biggest issue in translating care is not about the lower middle income country, but is about how they go about selecting populations in those countries. This is a challenge in of itself, and one I think we'll discuss a great deal more when we flip the classroom. But I think it's very interesting to understand in trying to translate this therapy, what it is that we are doing. And I think the biggest focus really should be more about understanding the infant with encephalopathy and the cause of that encephalopathy than necessarily the cooling technology itself. Well, what about some other issues that have come up around cooling? So here we've got that difference that I was showing you, very dramatic, regarding with or without strict entry criteria. There are other studies that inform us about some of the techniques around cooling. The NISHD did a study that looks at the depth and duration of cooling in infants with hypoxic ischemic encephalopathy. They wanted to determine if longer duration of cooling, so cooling for 120 hours, and deeper cooling, cooling to 32 degrees centigrade, are superior to the traditional techniques of cooling to 33.5 degrees centigrade for 72 hours. They did a trial that had a factorial design with 4 groups, traditional temperature for 72 hours, a lower temperature for 72 hours, a traditional temperature for 120 hours, and a lower temperature for 120 hours, and took a look at a primary outcome of death or disability. And it's a little hard, therefore, because of all the factors to sort of judge what's going on. But here's a table that shows us briefly that when it comes to the intervention, in this case, lower cooling compared to traditional cooling, we see an increased risk of mortality associated with the lower temperatures. When it comes to longer cooling, seen here below, we don't see as much of a difference. And the risk ratios are broad. And so there is real concern about the depth of cooling and the possible harms that we may cause. Another question that frequently comes up is the inherent question to the systems we work in and how babies do if they are outborn versus inborn. And we all know that the nature of hypoxic ischemic encephalopathy is it occurs in an unpredictable way in term and near-term babies, and so many of the babies we treat will be born at our community hospitals. Now, Narajan and colleagues looked at a secondary analysis of the NISHD whole body trial, and they suggest that there isn't a huge difference in the sort of results that they saw based on place of birth. They did note that infants who were born at locations other than the centers did have delays in initiation of therapy, 5.5 hours versus 4.4 hours, and lower baseline temperatures, 36.6 compared to 37.1, and more severe HIE, 43% compared to 29% compared to infants born at the NRN centers. They did not see a statistically significant result, but really much of that may be a sample size issue. And this figure from their work points out the huge differences between results if you're inborn and outborn. So if you look here, we can see the outborn control and the outborn cooled, and we'll look just here at death. Let's focus our eyes there. And we see that there is a significant reduction of death in the outborn babies that are cooled. Here we see the inborn babies I'm sorry, I got confused. This is outborn here, outborn control. Here we have the inborn babies. And we see that in both groups, cooling is beneficial. But we also can recognize very quickly from this that if we compare the outborn cooled versus the inborn cooled, we see huge differences there. And so the idea of modifying the setting that these infants are born in, or trying to work with our community hospitals, becomes very important. One of the questions that people have had is whether or not the initial severity of the encephalopathy makes a difference regarding the results. The fact is there's very little information on infants with mild encephalopathy. Very few studies have addressed that population. When we look at the studies that separately report moderate encephalopathy and severe encephalopathy, we see that at least when it comes to the outcome of death or major disability, that they are very similar and both successful in decreasing that combined outcome. The question then remains whether or not hypothermia should be offered to babies with mild encephalopathy. And authors have written on this question and have determined that there are certain factors that we need to address. First, whether we can actually define encephalopathy well in the first 6 hours after birth so as to accurately distinguish infants whose birth injury may be at risk for developmental consequences. And second, can mild therapeutic hypothermia improve mild neonatal encephalopathy, or potentially even lead to worsening outcomes? So I'll end this session with the fortune cookie that I opened when I was attending the NICHD workshop on cooling. The world belongs to the enthusiast who keeps cool. I think this is perhaps one of the most promising therapies that we have seen for term and near-term babies, but many questions remain. Where does the evidence take us? Who needs to be cooled? Which practices regarding optimizing cooling are best? And what is the future research needed? And I'm really pleased to flip the classroom with Dr. Marie Berg and Dr. Deirdre O'Reilly in the next session. Thank you very much, and we'll see you on the flip side. So hi, welcome to the flipped classroom. I'm glad you're spending what here in Vermont is a beautiful summer day with us to investigate this more. These sessions are sponsored by Vermont Oxford Network, who are the host organization for Cochrane Neonatal. As a matter of disclosure, I previously stated I am Vice President of Vermont Oxford Network and Coordinating Editor of Cochrane Neonatal. And so I don't think I have other financial interests to divulge. We're focusing, as you know, on therapeutic hypothermia, and we're joined by Dr. Marie Berg of the Johns Hopkins All Children's Maternal, Fetal, and Neonatal Institute, and Deirdre O'Reilly, the Associate Professor here at University of Vermont. Dr. Berg is the author of the updated review, and Deirdre has worked a great deal thinking about the regionalization of care here in Northern New England and the possibility of how we can best treat infants, including issues like the treatment of mild encephalopathy. So let's get started with the flipped classroom. And first, let me just give you a little bit of coaching to make sure that, in fact, you can participate in the polling questions. One, type your questions into the chat box if they're just general questions. We'll try to collate them and get to them for a more active discussion. But also, we're going to ask you some formal questions to get some idea about general practice. And you'll use the poll everywhere to answer these questions. There are 3 ways to use this. You can open your web browser and type in pollev.com/Vermont Oxford. You could download the Poll Everywhere app on your phone, open it after it's installed and join the presentation and type in VT Oxford, or simply text VT Oxford to 22333. So let me get some sense of this. I don't quite know where these results that are up here show, but if we could test out your polling capabilities, that would be great. Excellent. It's moving. I'm thrilled. Thank you. Kudos to Andy Warner, who always figures these things out for us. So first of all, welcome back to 2/3 of you, but I'm always thrilled to see new people joining us in these seminars and really look forward to your continued participation. So let's get to it. Some of the questions really have to do not just with the theoretical issues I discussed from Dr. Berg's overview, but what we actually do in our units. And we'd like to get first to a discussion of what you perceive as the known benefits and harms. So let's start. Trials of therapeutic hypothermia in infants with moderate to severe encephalopathy have shown a decrease in the risk of what? Mortality, moderate to severe developmental disability, mortality plus moderate to severe disability, or all of the above. So good to see that there is a little confusion. Some of it comes, I think, from that whole phrase of what the and or is. But Marie, you want to enlighten us about what the updated review tells us?
Absolutely, yes. So both the composite outcome of mortality and neurodevelopmental disability, as well as the individual outcomes of mortality separate and neurodevelopmental disability separate, are all significantly improved after hypothermia.
So this is just, again, this isn't a very precise, but this is the typical results from all of the studies. This is from whole body, this is from head cooling, this is from, and I kept misstating it, phase changing materials. And it shows that the combined outcome of death or major disability is profoundly reduced. If we look at that risk difference, that's suggesting that for every 7 babies we treat with cooling, 1 fewer baby has death or major disability. But whenever we create a composite outcome like this, people will wonder, is it one or the other? Are there now survivors, which in fact overall have a little bit more risk of disability? And the answer from Marie's review is no. In fact, it profoundly decreases both death and major disability. And so it seems to be a win-win all around. So what about harms? Do trials of therapeutic hypothermia in infants with moderate or severe disability have increased risks? So it's interesting as we see this balance out. Marie, comments?
So yes, most of the respondents, 2/3 of the respondents do say thrombocytopenia is the one sort of significant risk, and that does remain significant in this version of the review. PPHN is an interesting question because different trials defined it differently. Some of them just said use of inhaled nitric oxide, some said PPHN, et cetera. So it's difficult. And some said PPHN or use of inhaled nitric oxide, and we couldn't end up including that. My guess would be if you were able to take all comers, you may find some borderline significance, but I have played around with that, to be honest, and it still is, at best borderline and most likely not significant. So it's really just thrombocytopenia that is different. The question about, arrhythmia requiring treatment and hypotension requiring treatment, I think many of us clinically do see, certainly these babies have sinus bradycardia, we absolutely know that. Certainly some of them require, have lower blood pressure. Whether that gets to the point of requiring treatment, that's where it washes out and it doesn't end up being significant. So
the point estimates of some of these things do suggest an increase, but the confidence intervals, except for thrombocytopenia, don't. I suppose that this question becomes more relevant when we think, and we'll discuss later, when it comes to introducing therapeutic hypothermia to infants with less severe disease, and whether or not these issues might become more problematic in that population. This is just a review of what you went through, Marie. Again, for some things like arrhythmia, The confidence interval is broad, but does not really suggest a huge difference. And the point estimates tell us there might be more hypotension, PPHN, use of inhaled nitric oxide, and even coagulopathy, but only thrombocytopenia really we can speak of with more moderate certainty that it is a complication of care. Okay, what about the types of cooling? What do we know about the different types and whether or not they have any differential effects? Total body cooling with temperature survey control has been shown to be superior to all other methods of therapeutic hypothermia in infants with moderate to severe encephalopathy. This is always interesting to see these things balancing around, but Marie, tell us.
Yes. So the answer is B, it's no. There have been reviews basically looking at comparison between these methods, and they really haven't, nothing has really washed out in terms of an optimal mode. They all are equivalent. Now, what's interesting is that, and I'm not even talking about this specific review, but what's interesting is that they do see potentially a risk of overcooling with phase-changing materials, water bottles, et cetera, things like that, that are not servo-controlled. But nonetheless, as we see in this review here, and you're showing in the data, with the exception of basically there's some, disability in particular for phase-changing material, most of these things are clinically significantly improved via therapeutic hypothermia, regardless of the modality. And so, if we're for disability, that is a question, and I think it may kind of, we can kind of look into what it's a question of assessment tools. It's a question of who the infants are that are being cooled in these countries, because many of the phase-changing material studies are from low and middle income countries for obvious reasons. And so, that's kind of a question mark. It's different metrics that are being used for disability, but by and large, no difference.
So, these points, and I see in the chat the question about passive cooling, the idea that some of these techniques are successful, not just in low and middle income countries, but might have a role in our context. We talked a little bit about the outborn infants. Thoughts about that, about passive cooling, about instituting cooling with phase-changing material, and then converting kids to other forms of therapeutic hypothermia?
Oh, absolutely. There have been multiple studies, both starting passive cooling and / using sort of cooled water bottles in the beginning, as well as, for example, in the ICE trial, just using cooled water bottles applied to the body throughout. And they have basically shown an improvement in death or disability. The difficulty that I think we can run into is, who are the patients? I think ultimately it really comes down to that. Who is being cooled rather than how they are being cooled. Certainly on cooling on transport, I mean, coming from Vermont and having tried to do passive cooling on transport in the winter, a lot of babies got very cold, and that's always while we work the kinks out, and that's certainly something that you can risk. But ultimately, the choice of modality can be used regardless of setting. Phase-changing material, et cetera, in the ICE trial was fine. Now, transport cooling, there are now servo-controlled mechanisms that I think are probably a little bit safer in terms of reducing the risk of overcooling. But I think the biggest thing is identifying the right infants and having your center have a protocol for how it's being done.
The term passive cooling came up in our chat. And, I did not present a slide of some of the secondary analyses, I believe by Laptock and colleagues, showing that in the overall population, not just the cooled babies, it's the babies who got warm that had poor outcome. And might it be fair to say that not warming is an effective therapy, or at least something that should be considered? And I think that's what is wrapped into this question of passive cooling. Deirdre, I see you unmuted. Do you have some thoughts?
Well, yeah, I just wanted to chime in about passive cooling because that's a particular interest of mine. And I think, Marie, you hit at this, which is that the most important is the temperature management, I think, rather than what's used during transport. and accurate and using it accurately. And so there have been advances, and as you mentioned about servo control being available during transport, but that's not always possible. I know we still don't have that. So we, make sure that our transport team adheres to our protocol to check the temperature every 15 minutes and to make adjustments if the baby is seeming to get overcooled. But I also agree with your comment about warming. I think that's just as important as making sure that they stay within that target range.
Yeah, it's also, I guess these are all just arguments around the evidence, not of the evidence itself, but the idea that deeper cooling didn't do any better, does make you sort of think maybe it's more about not warming than it is just about cooling. All right, so ILCOR recommends, of course, that we adopt this therapy and that we make this part of our standards of care. So in the next set of questions, I want to explore, what do we actually do with our cooling? And so I'm going to ask you whether your center has formal guidelines addressing the indications and the methods, so the who and the how of therapeutic hypothermia in infants with hypoxic ischemic encephalopathy. So I'm proud to see the 96%. I'm not going to shame the few who don't, but this is low-lying fruit. For the few of you that have not spent the time to write your protocols, this is the time to consider it. But even of the 95% who said you have protocols, let's examine this a little closely. So does your protocol have formal guidelines addressing the gestational age of infants who you'll cool? Now, I recognize that some small percentage said they didn't have protocols. I guess the answer to that is no. What I'm looking for is about the precision of those of you who have protocols. And I'm going to kick it back to Deirdre and Marie about, what do we really know about cooling in lower gestational age ranges, both in terms of evidence and practice?
Yeah, it's good that this is coming up again, because one of our earlier questions from Mark Hyatt was, what is the lower threshold for gestational age or birth weight for cooling? And I think the answer to that is there is no one gestational age or birth weight. I think each center has their own interpretation of what that is, and where the risks outweigh the potential benefit. And this is where the issue of thrombocytopenia or other bleeding complications really play a role in those of us who care for these infants. Once you get beyond the late term gestation, we really worry about these complications, because we know that we see it even commonly in the full term infant population, whether it's some degree of intracranial hemorrhage. To think about a preterm infant with immature brain at that stage, it's really risky. It's theoretically something where we could have a very unfortunate consequence of the therapy itself. So that, I would say most centers probably stick to the 36-week gestational age, but many other centers between 34 and 36 will continue to consider it on a case-by-case basis, depending on the birth weight of the baby. If it's a large for gestational age infant, or the dates were uncertain, it's sometimes, in my personal experience, can be hard to withhold the therapy from a baby at 35 and 6/7 weeks, just because of that 36-week gestational age cutoff.
35 and 6.5 weeks. Marie, you've had some experience with this. Would comfortable sharing it?
So my group actually just got a case report accepted where we did cool an infant at 35 weeks, and there were certain circumstances and reasons we did that, and it was certainly a baby of a decent size that would have been eligible based on birth weight alone for the most of the large randomized controlled trials. But we had a long conversation with the family about risks and benefits, in part because the studies looking at sort of late preterm infants do show increased risks of mortality, things like that. So things that you might expect for preterm infants to be respiratory distress, potentially thrombocytopenia. And so, it is a conversation individually to have with the family about the fact that this is not well understood. And I think certainly for the 34-week infants, in my experience, we actually tend to have on that in our protocol that we would refer them to the quaternary care center that's nearby for consideration, just because it is so poorly understood in that population. But I think, as Deirdre said, it's just important for your group to have an understanding about your practices and to take it under consideration when you have these other babies.
This general theme is going to come up with the next series of questions, that we all have deviated at some point from the specific information provided by the trials. But I would argue that your guidelines should reflect your interpretation of the trial's data, understanding that there will always be circumstances, 35.67 to engage the parents, but have the guidelines as the representative of how you've interpreted the data, and anything in those interstices outside the guidelines is a shared decision making with the parents, and not necessarily up for us just to say, oh, I will or won't do it. So let's move on. Again, asking about your guidelines, formal guidelines addressing the severity of illness of infants with hypoxic ischemic encephalopathy. And I see the vast majority say yes, some are uncertain about that. And by this I meant, do you have a description of what constitutes severe enough encephalopathy to consider cooling? And that's a tough one. And let me toss it back to Deirdre and Marie before I throw in my thoughts.
Yeah, I think for those of us who spend a lot of time in the NICU, this is one of the most difficult questions to answer. Clear the benefit for moderate to severe encephalopathy, but still not sure that even though we know that infants with mild encephalopathy have an increased risk of brain injury on MRI, the studies that have been done, somewhere around 20%, we still don't know, at least I think, whether that degree of injury confers lasting developmental consequences. I'm certainly very worried about it, but these children are very hard to follow, at least in our population. I just recently did an analysis for our almost 100 kids that we've cooled recently, those who had mild encephalopathy, and whether we cooled them or not, we're not doing a very good job of following them up. And so, unless you're in a research heavy center, which is wonderfully that a lot of centers are, but I would imagine many of the people on this call don't have the resources as well to follow these children and do the standardized Bailey examination at 2 to 3 years of age. So it's a really difficult question to grapple with.
I think when everyone sees this question, they think about mild encephalopathy, but there's also the question of how do we define moderate and severe encephalopathy? And it's not so easy because the trials had various levels of stringency. And you'll see when we talk about the results in LMICs that seems to be a big question. Here we just reiterate the fact that 75% of hospitals in the UK survey offered it to infants with mild encephalopathy, and most of them thought that it was because it was relatively safe and there was a possibility of averting long-term damage. All unknown. Let's hit the last couple of questions briefly. Let's start with the fact that, are there limitations in your guidelines around the age at which you'll cool? And most people who are sticking with us, who have guidelines, say that that's part of it. I did not know how to interpret the UK study that said that a significant number, 1 in 5, allowed cooling up to 12 hours. I don't know whether they were reporting their personal experience or whether that was part of their standards. And I'd love to hear what your standards, what you guys think the standards should be regarding chronological age.
I think from my standpoint, looking at the studies that have been done on late hypothermia, most notably the NICHD study, they did find, while there wasn't in the traditional sense a statistically significant improvement in death or disability or the combined outcome, they did, when they did the Bayesian analysis, think that there was probably about, I think it was 75, 76% chance that the treatment would be of some use, of some utility. However you look at that kind of analysis, what is clear is it didn't harm the infants. And so, there was no worsening of death or disability. And so I think that most centers will probably should continue to stick to the 6-hour mark in the absence of other data, but that, I think just like we talked about for gestational age or other kinds of issues, if you have an infant that is past that time, and I think I saw Dr. Escoto in the chat referring to an infant that he had taken care of recently who ended up getting cooled at 8 hours, there's no reason not to do that if they're basically you feel like that if there's a potential that your baby might benefit because you're unlikely to be doing harm at that point.
No, so. I mean, I would agree, except I do think it's important to still aim at the 6 hours, the proven window.
Absolutely.
And in terms of the systems that we create and the expectations in referring hospitals, I would hate to see people move away from that based on I know you're not saying that, but I understand in my hands, if someone came in at 7.5 hours, 8 hours, surprised me with a seizure in that time or something that made me recontemplate, of course I would cool. But I do think that our goal to work out in systems, early identification and treatment is still quite important.
Exactly. I mean, the case that Dr. Escoto mentioned, required a bit of a workup in order to establish whether there was HIE. And so if, at that point, I guess you go for it, but I agree that 6 hours should remain. So,
right. And I'm confused and did not pursue whether or not in reporting that 20% or so of the centers cooled up to 12 hours, whether it meant they had experience with it or were willing to do it versus thought it was the ideal protocol. All right, so here's a big question that we're going to sort of finish with, and that is, should centers in low and middle income countries consider using therapeutic hypothermia? And let me read this right, because I use double negatives all the time. Centers in low and middle income countries should not consider it. So you're saying that you would take the commentary from the Helix investigators and say that they should not be doing it. And this has got lots of lively movement to it. Glad to see the majority thinking that they should still consider it, but I see that there is more uncertainty there. And it's hard to know with the wording of this recommendation as opposed to our findings, which were actually investigators in low and middle income countries were quite successful in their trials, most of them using phase changing materials, I got it right that time, without servo control, and that the real issue comes from the issue of how in those settings are infants judged to be acutely harmed by their encephalopathy. So any other comments, Deirdre Marie?
So I think you had, Roger, you were nice enough to send me the comments from the neonatal, National Neonatology Forum in India that Dr. Suresh had sent you. And so thank you to him for those. And I think they put it really well, actually, basically that what it seems to be in large part, as we can see in this slide, is who the babies are. So, certainly when we separated out in the Helix trial, we separated out from, as anyone can see in their appendix, the outborn and the inborn infants. The inborn infants met the strict criteria that was present in the initial NICHE trials, et cetera. The outborn infants, what was the only criterion for perinatal asphyxia was whether the babies basically were crying at 5 minutes. So, and that's understandable. We know that those other centers aren't going to be able to get you a cord pH necessarily, but those infants, basically didn't do as well with the hypothermia, and that was actually the majority of infants in that trial. So if you actually separate, and we ended up separating out the inborn and outborn infants from Helix trial in our study, as we did with one other study. And really it kind of comes down to, and that's what this forum said, who the infants are, whether they're inborn or outborn, whether they have a cord pH less than 7. Those infants definitely should be considered for cooling, and then others on an as needed basis, because there was an increased risk of mortality, and want to avoid that. But yeah, so I think there's more to be said, but I don't know that we are quite ready to say that low and middle income countries should not cool.
Well, I agree, but so much interesting research about the population, both here in higher income settings in terms of the timing and the degree of encephalopathy, but also what are the right criteria to select patients. We all grapple with this. The explosion of chat is incredible. I thank everyone. I recognize we didn't get to a lot of it. I'm going to ask Andy to print it out for us, and Deirdre, Marie, and I will make our efforts to sort of circulate this and keep the conversation going. I'm going to close things out, though. My favorite fortune cookie, obviously, and just talk to you about and invite you, especially those that said they hadn't been to Vaughan Grand Rounds or Cochrane sessions before, to join us in our upcoming sessions. We've got the folks from Rady Children's talking about variants of uncertain significance in our genomics grand rounds and the other topics here, as you see. So again, thank you very much for joining us on what, at least here in Vermont, is a beautiful summer day. I look forward to continuing to engage you in these seminars. Deirdre, Marie, thanks. Andy, thank you very much for setting this all up. We'll see you hopefully in September.